Thank you for being here. Thank you to the wonderful panel. So many of you may have heard me talk about IVUS, or hopefully if you haven't, you will after this talk. But I'm going to make a case over the next 10 minutes about why intravascular imaging is going to be key for everybody's practice moving forward if you're not already using this in your peripheral interventions. These are my disclosures. So we've spent a lot of time, and you can see what Dr. Metzger is working on right now, moving from a very small group of lesions that were guideline indicated for endovascular treatment to where we are now in 2022. So we've seen with every guideline iteration, every task reclassification, that more and more complex disease is necessitating an endovascular first approach. But we haven't perfected our art. We still need some tools to really get the outcomes we're looking for. And I just highlight here amputation rates from the Veteran Health Administration. You can see over the last decade, we've been not only not plateaued, we're slightly going up over more recent years. And so we really need to think of how do we get more durable results from our treatments. We've got more tools than ever. We've got drug-coated devices, biomimetic stents, atherectomy, re-entry devices. What else can we do to improve our long-term outcomes? And again, I'm an interventional cardiologist, and we use a whole lot of intravascular imaging in interventional cardiology right now. I would say about 60 to 70% of my coronary interventions are done with intravascular imaging, and these data are the reason why. You can see here that intravascular imaging in the coronary space, which is not too dissimilar in the size of those vessels below the knee, can result in not only hard endpoint reduction like cardiovascular death, myocardial infarction, but also stent-related events, target lesion revascularization, and stent thrombosis. So I'm going to use this as the platform of how we move from using intravascular imaging in the coronary space into the peripheral vascular space. So why is IVUS an important adjunct to angiography? Well, we all see this in our practice. I saw this just the other day. When it's very hard sometimes to tell how significant a stenosis is on an angiogram alone. And you can take 2, 3 orthogonal views and use a lot of contrast. You could also pass an IVUS catheter and see this pretty clearly. It's very important, as everybody knows, to look for plaque morphology, in particular grading the degree of calcification. And I'm going to convince you in a few moments why lesion length as well as reference vessel diameter are really hard to calculate based on the QVA or QCA or angiogram versus IVUS catheter. So I'll make the case here that IVUS wins in the majority of these situations. Passing an IVUS catheter gives you a better sense of your lesion length, your vessel diameter, the orientation of your wire crossing, understanding plaque morphology, grading disease severity, grading calcification burden, understanding dissection importance, and then looking at stent apposition. Everything we think about and every other vessel in our body we should be doing in the peripheral artery as well. So this is what you can see on an IVUS catheter if you haven't spent much time looking at peripheral IVUS. So on the left here, you can see nicely a deep dissection extending back into that media. And you can see some speckling of blood here with the chroma flow on the Phillips catheter system. This is really a dissection that is going to abruptly close most likely or restenose in the near term. So these are the ones where we are more aggressive about whether we use a TAC or a scaffold and even prolonged PTA. But these are ones that are unlikely you can walk away from and get a good long-term outcome. Here you can see deep calcific plaque. So this is not intimal plaque, this is farther back in the vessel. And so newer tools like intravascular lithotripsy is going to address this much better than a traditional atherectomy device. And then this is the dreaded stent malapposition. So you don't ever want to leave a stent like this. This will restenose or thrombose. If it has drug on it, it will do nothing. So you got to go back and make sure that you oppose these stents if you want to get the true treatment patency that you see in those randomized trials. So I like to just show some images where we get misled by an angiogram. Here is a proximal SFA. It looks pretty healthy. We would normally walk away that and look for the lesion we think is causing symptoms. You pass an IVUS catheter, you can see nicely that that is at least 75% stenosed. And if you probably took another view, 3 views, 4 views, you might see this stenosis. One pass of the catheter, you can see what you're missing on that angiogram. Here is a nice TP trunk recanalization. You can see patency of that vessel. In a normal situation, you take the angiogram, you say, great, that lesion's open, I'm ready to walk away. And if you IVUS this, you can see this deep, again, dissection, similar to what I just showed you, with blood tracking back into the median. This is going to cause hematoma back here. This can, again, cause either abrupt closure or really hurt your long-term patency. So what do the data look like? Well, this is a busy slide, and I just want to summarize that up until early 2022, we had a lot of great cohort studies, observational studies, case reports, case series, talking about how IVUS has an improvement over angiogram alone for many of the different topics I just talked about: device sizing, lesion characteristics, dissections. But these were all primarily retrospective observational studies. In early this year, we had our first randomized trial published in JAK interventions, looking at a prescribed algorithmic approach to SFA POP intervention when IVUS was used with angiography versus angiography alone. So 150 patients randomized into two arms, one with IVUS, one without. And the powered endpoint at 1 year was binary restenosis. You can see here there was a 17% reduction in binary restenosis at 1 year. This is not powered for clinical endpoints. This is powered for restenosis. And the majority of reasons why we think the outcomes were better with IVUS was a more purposeful selection of devices, more purposeful treatment of complications. So you can see on the right here that when IVUS was used a larger drug-coated balloon by at least a 0.5 millimeter, which likely gives you a better outcome with that treatment device. And when you think about it on the operator side, if you did an angiogram and you were asked, what is your plan? And then you're given the IVUS images and you say, now what is your plan? 78% of operators did something different based on the IVUS images, whether that was looking for a larger treatment length, device size, or other changes to the treatment plan. I think my Siri is talking to me right now. 2022, right? So, and then on the other side of it, why was there disagreement between angiography and IVUS? Well, you can see that most often, as I highlighted earlier, and there is reference vessel diameter and treatment length, we really get wrong on an angiogram. It's really hard to see diseased vessel on an angiogram alone. And again, it's really hard to quantify the vessel diameter. And then again, I think really importantly is grading severity of dissections and understanding how to approach these dissections. We've got a lot of tools now. Again, I highlight TAC. We have short scaffolds. We have obviously balloon angioplasty. So there's a way to deal with these, but you need to be able to see them, detect them, and these are what are going to change your long-term results. So this is a 1-year study. We showed binary restenosis down by 17% at 1 year. Let's look longer term at clinical endpoints. So Dr. Rosenfeld, Sahil Parikh, and others worked with me on this study looking at our Medicare patients. Medicare patients are great because the majority of people with peripheral artery disease in this country are 65 and older. So we had 540,000 peripheral interventions done over a 4-year period. And already, without everything I'm showing you, about 12% of people were using intravascular imaging. Now, the nice thing about this cohort database is we can get patients from all different clinical scenarios. So ASC, OBLs, outpatient centers, and inpatient centers. We could look at critical limb ischemia versus claudication, the arterial segment recanalized, and then, like I mentioned, the procedure location. So this is going to be published formally on October 24th, but what we found in this study over the long term, 3.5 years of median follow-up, is that with IVUS imaging, taking that restenosis of 1 year and moving forward, there's a number needed to treat of 40 patients to reduce a major adverse limb event. And you can see number needed to treat of 100 patients to do an acute limb ischemic event, and number needed to treat of 50 patients to reduce major amputation. So we saw pretty remarkable benefits from just having IVUS technology available as a diagnostic tool to guide your revascularization procedure. So I'm ending what my friend Srini highlighted earlier, is that we also followed earlier this year with the first ever expert consensus document on the use of intravascular imaging. And this had never been done. This is really a unique approach, again, with Ken Rosenfeld and Sahil Parikh as my colleagues running this. Dr. Runback was part of this. Fabricio was part of this. And so what we did was we created with a 12-member steering committee, writing committee, clinical scenarios where we thought IVUS might be utilized, whether it's in the early phases where you want to do a diagnostic run to get how much calcium is in the lesion, what's the reference vessel diameter. We talked about the intra-procedure phase, when you've now done something like atherectomy. Are you done doing atherectomy? Do you need the stent? Are you going to balloon alone? And then the final run, are you going to look at that stent? Is it opposed to the vessel wall? And we created a bunch of different clinical scenarios. We had 15 independent experts who didn't design any or have anything to do with this study vote on these different scenarios. And then we came to consensus where we thought IVUS would be useful. So the full document is online. You can see on the left here, these are the arterial experts that took place, and many of them are on faculty here right now in different specialties, including vascular surgery, interventional radiology, and interventional cardiology. But there was a lot of support for intravascular imaging among this group. You can see on the right here, this table, and again, this is just a snapshot of the results. There was a fair amount of consensus that IVUS was useful, primarily in the early and the later parts of an iliac intervention and SFA POP intervention. So people really felt strongly that IVUS can be helpful for guiding treatment strategy, but also that final run, making sure if you do place a scaffold, it's well apposed. If you do have a dissection, you interrogate it a little bit more closely. The most resounding consensus in this document was in the tibial space. So any below the knee vessels that you're treating, we know that sizing is really difficult. We've seen a lot of device failures really fail recently, Seval, drug-coated balloon trials, and I think sizing has been the big part of it. So I think that's my current call. I just want to highlight again that I think moving forward, we're going to see a lot more in intravascular imaging for FemPop intervention and also below the knee. If you're not using this technology, please come find me. We have a lot of tools to help you get primed on interpreting these images and thinking about how to use this in your practice. Thank you very much.